Good evening, everybody. It is a pleasure for me to be at this webinar, the Q4 TAVI webinar, sponsored by Abbott, on overcoming anatomical challenges in transcatheter aortic valve implantation or replacement. I have the pleasure to have the company of two amazing speakers and excellent interventional cardiologists. We have Dr. Amber McCanny. She's an interventional cardiologist and a structural heart disease cardiologist at UPMC in Pittsburgh. We also have the presence of Dr. Michael Chenier. He's an interventional cardiologist specializing in structural interventions at Mission Health in Nashville, North Carolina. And I am Mauricio Cohen, Medical Director of Structural Heart Interventions at Cleveland Clinic, Florida, located in Weston, in South Florida. So this is the agenda for today. What I'm doing now is the introduction. Then Dr. Chenier is going to give us his insights about risk factors for vascular complications and access strategies. Dr. McCanny will present the delivery system for the FlexNav platform and then present the case. Then I'm going to follow with another case. And then we're going to go to Q&A and key takeaways. For all the attendees, remember that there's a chat box where you can ask questions, and we will hopefully be able to answer as they come during the presentation. So without any further, present the conflicts of interest. Those are for me, for Dr. Chenier, and for Dr. McCanny. And without any further ado, we're going to ask Dr. Chenier to take it away, presenting his lecture on risk factors for vascular complications and access strategies. Thank you so much, Michael.
All right. Thank you, Mauricio. So I'm glad everyone's on the call tonight, and hopefully you'll find this useful with some actual practical aspects that are relevant to all of us who do TAVR. And I think we'll go over some tips and tricks, and then also the advantages of using this particular valve and delivery system. So next, please. So I wanted to start off, I hope a lot of people saw this data that was presented by Vinu Thurani and Joan Michaels just recently. And this is all from the TVT registry. And if you haven't looked at it, I'd encourage you to do so. There's a lot of data and slides in that deck that goes through a lot of trends of what's happened in TAVR over the last 10 years in particular, but even longer. And what's relevant for this presentation tonight, I think, is focusing on where the vascular access and complication challenges arise has really evolved over time. And if you look at the TVT data, the femoral access rates have stayed pretty persistently high over particularly the last 5 years. But going back 10 years or more, of course, we know that transfemoral was used even less frequently, and we had different alternative access routes. So go on to the next slide, please. Historically, if we weren't going transfemoral, what I would highlight here on this graph is we were doing a lot relatively of transapical access. For those of you who were doing TAVR at that time, you remember those cases. And that has really dropped off dramatically since then for good reasons. The sort of green line was direct aortic. That has also dropped off. And then what else I would highlight is the orange line. If you go from left to right, now the most common access that's alternative for TAVR is transcarotid. And I think everyone recognizes that in practice. The data is good to support that. And the rates are still relatively low, but you've seen a steady increase in that, and with the drop off and everything else. Transcaval has always been a low usage, even since the beginning when that was starting to be done. The centers that still do a lot of transcaval access do it very well, but I think for the majority of people who are not doing those on a regular basis, that's really not a feasible option for most. So go next. And why that matters is vascular access complications also correlate with the route that we're using. And so if you correlate the same time trend, you can see that bleeding rates have dropped, and major vascular complication rates have dropped over time as we've shifted more to transfemoral access and transcarotid access. And it was single digit even 10 years ago, but there's still been a steady decline since then. And I think we can continue to do better. And hopefully this talk will provide some strategies for those really difficult cases. Go next. So when I think about vascular complications for my TAVR patients and the risks that that's going to be posed to them, I really think of four things. This first slide is going over the first, and I touched on it already a bit. Access route inherently itself is going to change your risk of complications. And so this is a little bit older data going back a few years, but basically the bottom line is that transfemoral complications are low. They're single digit. Contemporary data is about 1%. In the early partner trial data era, high and extreme risk trials, those patients had, even the transfemoral ones, complication rates up to 10 to 15%. So what does that mean? You know, of course, the vascular access complications requiring blood transfusion, surgical intervention, or a combination of both. Alternative access risks are inherently higher, right? So, and that's intuitive, but we know that from the data as well. But the most favorable outcomes, as I've touched on already, is the transcarotid approach. Transapical and central access has really gone to a historical route. Of course, we still use those for very rare cases, but I think that's not going to be as relevant for most centers, but something to just be aware of. And I still think there's a role, obviously, for the surgeons to know how to access those routes. And there's obviously other valve technologies, too, that's relevant for. Next slide. The other three things that I would mention that I always think about, so access route inherently is going to change your risk, right? But is the vessel itself a problem, right? And I'll show this case in just a second. Is your angle of the aortic arch or your valve angle, is that a problem? Because that's going to give you some risk. And then is there body habitus in general, right? Those are really the four things that I think of that I have to be cognizant of when we're planning for these cases. This case is a real case that we ended up doing, but terrible vascular path. I mean, 77 years old, had a carotid-to-carotid bypass, ligated right common carotid, has residual severe right subclavian stenosis, has a AAA with nasty layered thrombus, has severe CFA and iliac disease bilaterally, and she had a prior 23 millimeter trifecta, so small valve with a root enlargement at that time. And even at the time of her surgery, had mobile atheroma in her arch that was resected. So these are gross cases that are going to be really challenging. And I'll ask my other panelists here in a couple minutes about kind of what they think about for this kind of case. Go next. So here, back to my 4 points. The third is the aorta angle itself, or the valve angle itself, going to give you potentially some problems with vascular complications. This is a case who's had a prior ascending aortic graft in addition to their bioprosthetic valve. Now that valve has failed, needs to be replaced. And it's a little small on the screen, but you can see the angle for the valve is quite steep. You can see this kink in the aortic graft. The aorta and the arch is very angulated. You've got two 90-degree bends. These are challenging cases. So how are we going to minimize this person's risk of vascular complications, but also ensure that we're delivering a TAVR valve inside this safely and effectively? Go next. And then my fourth thing that I always think about is obesity. So if your patient's abdomen or their pannus is extending beyond their CT field of view, how are you going to plan to address that, right? So those are all really difficult, challenging cases that we'll all see at our centers, and those three are patients that we ended up treating, and happy to talk about those, particularly in the next few minutes. But Mauricio and Amber, I guess before we go on to the next slide, I'd pose two questions to you, and maybe you guys can chime in. So first, for really heavily calcified femoral vessels, how do you adjust your approach to prepare the large sheath to go in, and then when it's coming out? And then second, the TVT data really doesn't do a good job at capturing this, but for this patient that's on the screen, or at least partially off the screen, how do you adjust your approach for these really severely morbidly obese patients? Are you doing femoral cut downs? Is it alternative access? What are your thoughts and strategies for those? I guess we'll pause there for a minute.
Amber, do you wanna start?
Yeah, so I think that I was actually going to pose the question kind of to the team, similar to what you asked, is that, you know, in the past, I think we were fairly quick to think about calcium modification in femoral and iliac arteries that were heavily calcified. I think that we've gotten so savvy and can do alternative access approach with such finesse that I think that even those skills seem to be a little bit more in the rearview mirror, much like the other access points that you had suggested. And so I do think that with regard to vessel preparation, I think in my mind, if there's any question, typically we're looking at the option of alternative access. If alternative access doesn't seem reasonable, then I think that considering calcium modification in the iliacs and femorals seems appropriate. Certainly there is still a role, I think, for vascular cut down in some cases. But I think that we are very quick to go to alternative access. And similarly, well, I should mention, in addition, in those patients, I think we have a very low threshold. If there's any concern for degree of stenosis there, to consider, you know, even doing angiography of the vessel afterwards, just to make sure. You know, I was always taught that you want to really stick the landing, and I think nothing is worse. We've all been in this position that the valve procedure actually goes quite well, and then you take the patient out and you find out that they have a cold foot. And so I think that our strategy really is a low threshold to think about alternative access, and to think about really imaging the vessel afterwards if there's any question about it. And similarly, I think for these morbidly obese patients, I'm from Pittsburgh, and so we find this to more often than not be a more common body habitus than we may find in other parts of the country or even the world. But patients wear their weight differently. And so I think that to some degree, you'd never really know how challenging the vascular access is going to be until they're actually laying flat on the table. So I think it's appropriate to really look at their alternative access to prepare the patient for that possibility. If it looks like their weight is kind of distributed right around their groin area. But we've always been surprised in some cases too, where we expect to have to go through an alternative access route to decrease the risk of bleeding. And then the patient's actually laying flat on the table, and you see that they are carrying it more kind of in their chest area, or when they're laying supine in general, that they don't carry too much weight kind of in their groin area. And so but I do think in these patients, having the conversation with them ahead of time about alternative access possibility is important.
Yeah.
What are your thoughts, Dr. Cohen?
So my thoughts are, well, we use ultrasound. So you can, you know, for the calcified vessel, you don't want to feel that when you advance that needle, the vessel cracks, because that's kind of ominous. You know that you're not going to be able to deploy the prog lights to do the post closure. So that's not a good thing. So you have to find the right spot where to stick, where the vessel is free of calcium, and to do that, you have to study the CT scan way in advance. Obviously, you have to study the CT scan, and then if you need to study also the trajectory of the vessels, the curvature of the vessels, whether or not you can overcome a significant calcified bend. If that's not the case, go to an alternative access. Then using IVL, that's our calcium modification strategy of choice in our program. It's important. So sometimes you may think, this platform has an inline sheath. So for example, for those bends that you see in the aorta, you may want to think about, putting an 18 French sheath or a 15 French sheath or a 20 French sheath, whatever the specification is, because that's going to traumatize less the vessel, and that may give you a little bit better support to overcome the tortuosity. And the cases you showed, Michael, with the angulation in those prosthetic valves, those are very complicated because the valve will turn around and then it will fall in the sinus of Valsalva and not make the turn into the ventricle.
Right.
So in those cases, what we have used is a little snare just to lift the nose cone and then redirect the valve into the prosthetic valve. But these are very interesting cases. In terms of the obesity, you can always measure the depth of the vessel of the femoral vessel with from the skin, and that can help you predict whether or not you can actually do the procedure and have a successful closure. Because if you have to call a vascular surgeon to do a cut down or to do a vascular repair, it's a nightmare. These patients don't heal well. So I think that the carotid, the carotid alternative would be more appealing in these cases.
Yeah, I 100% agree. I think both of you made perfect points there. And so for this obese patient in particular, so I think, Amber, your point is exactly right. Like you don't really know until they're on the table and how their weight is distributed, because sometimes, the getting down to the femoral is actually not that bad. And you can be a little bit fooled by the CT and when you see them in clinic compared to when they lie flat. For that patient in particular, it was incredibly deep down to the vessel. We knew that we did not want to do a cut down, certainly in that situation. The post-op seromas that these patients get are really problematic, plus the infection risk, obviously. So we ended up doing his case from a left subclavian approach, and it was no difficulty at all. So to your point, Amber, about where people's weight is distributed, this patient was almost 550 pounds. And but he carried it all down low. His neck and his shoulders actually kind of standard size. So and then in regards to the patient with the aortic prior surgical aortic valve with the aortic graft kink, that's exactly what we did. We went a left subclavian approach for that patient. We had to use a snare to pull in, and we're able to successfully deploy, and having to use a buddy wire, stiff buddy wire also, just to help navigate those turns. But all of these cases were Navitor cases, and I think that's another point you'll get to later on in the talk, is how choice of your delivery sheath and system, I think, is really relevant for these kind of cases, because there are some differences in terms of the different valve platforms about what your accessibility and what your risk is going to be. So, all right, go to the next slide, please. So you can go next. So we've talked about the route, right, from wherever our access point is through the aorta and into the aortic valve itself. But here is where obviously some other vascular complications that we all dread can come from, and that's associated with the calcified leaflets themselves and the LVOT. If there's bad calcium burden there, where we can run into some major vascular issues, as we all know, with annular rupture and other sorts of complications, including aortic injury that's not annular rupture, is really relevant here. I think that the other thing that I would note is when the valve itself is severely calcified and your angle is bad, if you're choosing a different wire in order to support your system and going in, usually that's going to be a stiffer wire, right? And if you're putting that into the left ventricle, then you obviously have a very dreaded complication rate that goes up, and that's the LV perforation because of those stiff wires. So for severely calcified valves, we have to think about that in and of itself. That feature is actually going to increase our potential for vascular complication risks inherent to passing the equipment across there. As we all know, balloon expandable valves they do expand better. Self-expanding don't expand quite as well with as much force, obviously, but they can conform in a safer fashion. And then if we're appropriately prepping those valves and those with an appropriate system for delivery, then we're providing those patients with the safest outcome we can. Go next, please. So for predilatation, we're going to talk about that on the next slide in a little bit better detail. but these are just basic, obvious things. If you're going to pre-dilate a heavily calcified valve, that's going to improve your likelihood that you're taking your TAVR system across without difficulty. You're going to also be able to assess whether the valve is going to expand. I have a slide that's going to be relevant for that later. Post-dilatation can always help correct PVL, potentially can optimize your TAVR valve leaflet expansion, particularly with the self-expanding valves. But there's some risk that's associated with that. So every time you're manipulating the valve, you have a higher chance for increasing stroke rates. You have a higher chance of injuring the annulus. So go next. So what I think we, or certainly I and a lot of TAVR operators used to do, is different than what it is now. I think when we are prepping an aortic valve to cross with our systems, most people are moving to, do a real pre-dilatation, right? Size it to what the annulus and what the valve is going to need. Those days of let's just see how the AL1 crosses, let's dilate with an 18 just to get some room and then see how it goes, I think that's really moving by the wayside. If you're going to do a pre-dilatation because you're concerned about the degree of calcification and you're worried about expansion, just do it. I think that's going to also help avoid the post-dilatations that are aggressive after you've implanted a TAVR valve. If you're concerned about PVL or under expansion, every time you inflate a high pressure balloon, you're going to increase that patient's risk. The picture that you see here on the right is an infold. So for those of you who have heard what an infold is but have not actually seen one, this is exactly what happens if you haven't prepped a valve appropriately. This is a competitor, obviously self-expanding valve. The patient that we ended up taking this out of, had a large annulus. This is a 34 millimeter valve, and had some moderate AR to begin with. So we were a little bit hesitant to pre-dilate initially, and their EF wasn't great. And so the risk that you run with that, though, is that if you don't prep the aortic valve appropriately and you start expanding your valve, if you get an infold, then that's a problem, and you're ending up taking out that valve most of the time, especially with an infold that's as large as this one. And then you're having time to spend to prep another valve to take that up. You've also crossed that aortic valve probably a couple of times at that point. You've increased that patient's stroke risk. Potentially you've increased risk of all sorts of vascular complications just with the exchanges. So I would just make that point that I think that the balloon sizing for what we use for pre-dilatation has changed over the last number of years. I don't know if you guys want to make a comment on that and what your strategy is, if that's different, especially for the larger valve sizes, the 35 Navitors, the 34 Evolutes. I think this is very relevant.
So I think a very aggressive, pre-dilation with a non-compliant balloon, I think helps. I think it prevents you from having to post-dilate. I'm always sweating bullets when I post-dilate, because if the valve is a little bit high and then there's a loss of capture, the balloon pops out together with the valve, and then you have a different situation to deal with. The sizing, so people say that you should size. I tend to size like 1 millimeter less than the average diameter. Some people say, well, use size 1 millimeter less than the smaller diameter. So I know exactly where the science is. I know what your practices are to size a balloon for pre-dilation.
Yeah, mean derived perimeters from the perimeter is what we use. Yep.
And use you undersize by 1 millimeter, or use just that? Yeah, that's what we use.
Adjusting also based on calcification degree, LVOT calcium, all those other issues. Yeah, absolutely.
Because it's different, because most of the times the calcium is in the leaflets, and sometimes you have a ball of calcium in the annulus, and that's where the risk is to causing longer bodies or causing just frank annular ruptures.
All right. It depends on the distribution of the calcium, right? So I think nodular calcium versus concentric calcium, there's such a big difference. So it's so important to look at the CT yourself. Our thought used to be really to use the minimum diameter for the balloon sizing. And I think the thought process was mostly to assist to getting the valve appropriately positioned and across the valve. And I think we all have really evolved into using more of a mean or, as you said, kind of usually using a -1 to 0 undersizing to appropriately get full expansion of the valve, because I think that, as you're showing, this is a very real fear without appropriate expansion.
Yep. And so for this case in particular, thankfully, it ended up being there was no issue. And we went in and we did a real pre-dilatation, didn't change the AR much at all. And he tolerated it just fine and got a appropriate size valve in and no issue. But yeah, those are the cases that make you remember for sure. And you guys go to the next slide. I think that maybe, yeah, we've talked about that already. So the perimeter derived balloon diameter, again, I think is where everyone has gone, and that's different from what it used to be historically. So, all right, go next.
Okay, perfect. Right. I think this is a segue to Dr. McCanny, who's going to tell us more about the FlexNav delivery system and the platform and the characteristics. Thank you.
Perfect. Before I do that, we've got a question from the audience. When you're navigating through tortuous anatomy and you choose to use a buddy wire, we are going through the alternative access site. And what type of buddy wire are you both typically using?
Almost always Lunderquist.
Yeah, me too. Yeah. Me too. I don't know how much it helps. I think it gives us a little bit of peace of mind, especially in very tortuous anatomy. But yes, I use, and then the other thing is that if you're going to use a Lunderquist, put it inside the catheter just to protect the vasculature, because that's like a coat hanger. That wire is so stiff, but the Lunderquist is, I think, is the stiffest in the market.
Okay, great. Thanks. All right, so I was going to talk a little bit about the FlexNav delivery system. Next slide, please. So this is kind of just in short what the delivery system looks like. So you've got the handle and as you can see, there's the major blue wheel is your main deployment wheel. It locks out at about 80%. So you get to kind of a similar kind of rumble when you get to that 80%. In order to go past the 80%, once you confirm optimum position, there's a button that pops up right ahead of the blue wheel that you're able to push down before proceeding with valve deployment. You've got this stability layer that kind of allows for precise deployment. And I think that's really useful with both kind of femoral traditional access as well as alternative access. And it's got the integrated sheath for when you're going through traditional femoral access, which is low profile. And we'll look at the next slide. It truly is kind of one of the lowest profile that you're going to find in the market.
Amber, I have a question for you. So
sure.
when you deploy, when you use this delivery system, have you tried using it by yourself, being the first, use your left hand to advance the device and the right hand to deploy? Have you noticed how easy it is? I mean, unfortunately, we have to work with a surgeon that likes to push the valve, but I feel that if you do it yourself, the left hand talks to the right hand much better. It's much better coordinated. And this valve doesn't move when you're deploying it. I don't know if you guys have experienced that.
I do, yeah. And I think that you make an excellent point. I think that if you have somebody who's at least kind of manning the wire, I do think that otherwise there is the capacity to be able to do this as a single operator. And you have a really intricate kind of control over the precision of the placement. So looking at the valve sizes here, you see that there's quite a range of treatment sizes. And in addition to that, the minimum vessel diameter needed for this valve is really less than any valve on the market. And so I do think, kind of going back to what Mike was talking about, treating patients who have challenging anatomy, who have small vessels, particularly our female patients or patients who have heavily calcified vessels, this is a nice platform because of the hydrophilic inline sheath, but also the minimum vessel diameter needed is smaller than the competitors. All right, next slide, please. And so looking at the cell design, you've got a large cell design, which as an interventional cardiologist is always kind of the dream with regard to handling these patients in cases of acute ACS. And so being able to access coronaries here is certainly less of an issue. you do have good radial force and good expansion as a result of it. I mentioned to you that the treatment size here is very broad. There's some kind of overlapping of the treatment sizes when you look at the size guidelines. And I think, that really allows us to kind of customize the valve that we're choosing based on kind of the anatomy that we're choosing, not just with regard to their annular dimensions, but also with the amount of calcium they have, their sinus sizes, coronary heights, et cetera. These leaflets are intraannular leaflets. And so we really do see patients' hemodynamics really not change significantly during valve deployment. Or if you, depending on kind of how rapid you're pacing, they quickly bounce back after pacing stops, just because the valve is fully functional when it gets to that 80% mark. And then the sealing cuff, I think, really does prevent some PVL, and it is a very sophisticated design for the sealing cuff. I think one of my favorite aspects of this valve, in addition to the large cell design, is really the radiopaque markers, these vision markers, has dramatically decreased the amount of repositioning that we've had to do with the valve. And I don't know if you I imagine that, Dr. Chenier and Dr. Cohen have noticed kind of similar things, but the positioning of this valve is really made much easier by these vision markers that allow for good precision here.
Absolutely. I think that is a huge advantage with this valve, is that when you place it where you want it and you start deploying, it doesn't move. So where you start is almost always exactly where you finish. And I would make back to the point of the left hand talks to the right hand. It's exactly that feature of the valve deployment that allows you to do that so effectively. So I couldn't agree more. And the markers are very easily seen. You line it up, and where you start, like I said, is where you finish. And that's a huge benefit, especially for these patients with these, crazy aortas and tight turns. This is where the delivery system and the valve itself, I think, provides a real advantage.
I completely agree.
And truly, I can't stress enough that I think the large cell design has implications that kind of go beyond the TAVR world. I think that it's not infrequent that these patients are presenting to their local hospital, which is a smaller hospital, of interventionalists who are not used to seeing patients with a TAVR valve. And traditionally speaking, those patients would be cathed through their groin, through the femoral access site, just because of a fear of challenges getting through a TAVR valve. I do think that this valve has made it very easy for patients to be cathed by anyone kind of with expertise level across the board because of the large cell design. All right, next slide, please. All right, so I was gonna talk a little bit about a patient with a very heavily calcified annulus in this case presentation. Next slide, please. So this is a patient that I saw not so long ago. She's a 76-year-old female, and she's got severe valve disease. In addition, she had some coronary artery disease, a history of a right bundle branch block with a left anterior fascicular block, hypertension, and COPD. Her ejection fraction was preserved at 65%. And you can see that her mean gradient's 49, peak velocity of 4.4. Calculated AVA and her echo was 0.6, and her STS prom is 4.5%. So I think that traditionally speaking, a right bundle branch block and left anterior fascicular block is something that makes us all cringe a little bit when we're thinking about a self-expanding valve. But I don't think it's something that really has been a deterrent from us placing this valve. Next slide, please. So our decision was to use a 25 millimeter Navitor and use the circular wire. I'll show you her access kind of in the next slide, but her access looks very amenable to placement of a 25 Navitor, just because of the presence of the right bundle branch block and left anterior fascicular block, making her a higher risk for requiring a permanent pacemaker after the procedure. Our decision in general is always with these patients who have a convincing underlying right bundle branch block, but certainly a right bundle branch block with a left anterior fascicular block. We almost always place a right IJ as opposed to going through a femoral vein for their temporary pacemaker. And as we talked about before, we as a kind of system-wide always pre-dilate for any self-expanding valve. And I think, as Dr. Cohen mentioned, we all fear having to do post-dilation. You're rapid pacing the patient, and you're hoping that the position of the valve is not so deep that you require pacing, but yet deep enough that you're not going to have a pop out. And it's truly a Goldilocks situation. And if it's avoidable, I think adequate predilation is truly the way to do it. So we chose a 20. In this case, we had chosen a Z-Med. We've since kind of gone to a non-compliant way of doing things. So we have transitioned to using true balloons primarily now. All right, next slide, please. So you can see her CT scan here. Her minimum annulus diameter was 20 millimeters, maximum is 26, average was 23, and the area derived is about 22.5. Her perimeter was calculated to be 72.5% with an area of 396. And this makes her a very amenable candidate for a 25 millimeter valve. And, thinking about this in other terms, this would really be a 23 millimeter balloon expandable valve. And so with what we know about patients with small annuli, I think that this valve in particular, but any self-expanding valve is always a better option here. And you can see that her calcium is to some degree nodular, but certainly not horrific in her annulus. Next slide.
Amber, before we move on, so so I have a couple of questions. So one from the audience: how much LVOT calcium is prohibited for TAVR? So any insight for Dr. Das, who asked that question?
Yeah, that's a good question. I think to some degree, similar to the annulus, I think it's the distribution of the calcium that really does make a difference. More than in my mind, more than the calcium quantity, it's the tapering and the size of the LVOT that I think is something that you really need to keep in mind. I think if there's significant tapering of the LVOT, you want to be very careful with the sizing of your valve. And I think that's where I find the overlap and sizing of the Navitor valve to be advantageous. So you can see that there is overlap, not just between kind of the 23 and 25, but mostly the 25 and 27 ranges when you look at the perimeter overlap here. And I think that it's things like LVOT size that really help guide you one way or the other. And those are important factors to take into account. I think that from my mind, a large burden of LVOT calcium is not prohibitive for TAVR, but it does warrant a deeper conversation with the patient about expectations. It's not, I don't think that I would consider TAVR in a patient with a significant amount of LVOT calcium that is nodular and concerning for a significant amount of paravalvular leak in a young patient who is otherwise a surgical candidate. I think that in patients who are older, or we can tolerate a little bit of PVL because there's no other option for them, I think that certainly TAVR is not unreasonable. But I do think having a conversation with the patient about expectations, because what I find is if you don't set that groundwork, patients are frequently surprised when they see paravalvular leak being read on their echocardiograms later. What are your thoughts, Dr. Chenier and Dr. Cohen?
Yeah, I think that's exactly right. I think that we're a lot more aggressive with doing TAVR when there's LVOT calcium now than we used to be. And mostly because we've learned that the self-expanding valves will often accommodate that, and your PVL might be mild, but that probably clinically doesn't matter too much. And so I think your points, Amber, are exactly spot on for having that conversation with the patient. Where I do get really concerned is where it does taper or when there is bulky nodular calcium. So on these kind of shots, when we see, it looks like a marble of calcium extending into the LVOT, I tend to try to avoid TAVR regardless of age, as long as they're a decent surgical candidate, just because those types of anatomies, no matter what valve you use, it's just a physical obstruction that you're not going to be able to overcome. And then if it's into the communicating with the mitral valve also, and in the anterior mitral valve leaflet, where you've got this really dense plates of calcium, and you're going to crack something, along that line when you're dilating with a balloon or putting just a TAVR valve in, I get a little bit concerned about that also in terms of injury to the surrounding tissues. So, but those are usually pretty extreme circumstances, right? I think, those are kind of obvious things when we see them, and we're a little bit more, facile with navigating LVOT calcium that doesn't have those extreme characteristics.
Yeah, absolutely. Dr. Cohen, any other thoughts?
No, I think that you said it all. I think we need to keep moving so we stay on time.
Next slide. Next slide. So, basically what I'm showing you here is that sinuses are adequate for this valve. They're quite large. And you've got a little bit of STJ calcium, but nothing that's out of the ordinary. Next slide, please. Coronary heights look very adequate. Next slide. And you see our angulation here. We've got an angle of 51 in terms of our root angle. And then our coplanar and cusp overlap respectively on the left and right. Next slide. And you can see that our calcium is by and far distributed on the leaflet. This patient's calcium score is 3,500. Next slide. Vascular access certainly looks adequate, especially for a otherwise relatively thin female. So not an issue here, but something to keep in mind in your thin kind of female patients, especially those who you're trying to get a little bit larger of a valve size for. I think this is an excellent platform just because the profile of the inline sheath. Next slide. And so you can see our cusp overlap picture on the left. I think we've got a good angle. You certainly can appreciate the degree of the leaflet calcium here. And the ballooning is pictured on the right here. So certainly a tight valve. Our balloon ended up being a little bit deeper than I would prefer, but next slide. You can go next, please.
That's a beautiful deployment. It's perfect.
Okay, great. The vision markers, you can see, I find them to be by and far the most kind of well visualized markers in terms of being able to do appropriate depth positioning here. And so we line up the attempt is always to line up the vision markers kind of at the pigtail or the bottom of the pigtail. And you can see our 80% imaging here. Next slide. All right, great. So this is our full deployment you'll see on the left. So a slow controlled deployment. I find that, you really don't need to be rapid pacing the patient. And I think a slow controlled deployment is really the most important part here. And the final imaging is noted on the right. So you see, I think there's a kind of misrepresentation of a little bit of PVL, partially because our pigtail ends up kind of swinging down towards the leaflet. Next slide. I can't remember if there's any slide.
So if you, in the previous one, so why did you decide to post-dilate here?
Yeah. There is some degree of PVL. Certainly, we knew that there's a large burden of calcium, and to be honest with you, this post dilation could have likely been avoided by doing a larger initial balloon sizing. And so I think that was part of the reason I wanted to show this case is that I think we all learn not just from each other but from ourselves. And so I think that this patient could have been pre-dilated using a larger balloon. I chose a 20 initially. But I do think a 20, it would have, or 22 would have been very appropriate, and a true balloon in particular. And there is PVL at the end of the last image, but I think that could have been perhaps prevented by more adequate preparation.
Yeah. So I've noticed that some programs don't use TTE anymore in the cath lab. Do you guys use TTE to assess PVLs or any other issues?
We do. We absolutely do. Yeah, we absolutely
do.
So
I think it's best practice.
Yeah,
I do think so too.
Always,
yeah. And we always actually do an invasive as well as a TTE gradient actually in the room, because I think that when you're just doing an invasive gradient, everybody's always surprised the next day when the echocardiogram shows it, a gradient that is significantly kind of changed or elevated from what it was the day prior. But we always do both simultaneously. And so an assessment with TTE and angiography is kind of what led us to post-dilate. And you can see that the frame truly does expand here with post-dilation.
Yes. And then also the invasive gradient is crucial, as you mentioned, because you not only assess the systolic gradient, but you also look at the AI index. So that means the separation between the LVEDP and the diastolic aortic pressure, and that gives you an idea of whether something is going on. If you see that the LVEDP and the diastolic pressure are touching, I mean there's something wrong. Whatever the valve looks like in echo, whatever the valve looks in angiography, there's something wrong there. So you have to investigate. So it's very important.
Absolutely. And we always teach the fellows the exact same thing, that's another important aspect of obtaining invasive gradients, is because you're not just getting an actual gradient, you're studying the curves and the morphology to see if there's PBL that you may not be necessarily detecting on echo, that it's a centric PBL.
So there's a couple of questions in the chat that I think we can quickly answer. So what size and brand balloon did you use to post-dilate? That looks like a true balloon, right?
Yeah, so that's a true balloon. It's a 22 true balloon.
Okay. And then the question after that is, so it's once you remove the navitor delivery system, how do you post-dilate? Do you insert a new sheath? Do you use same balloon or new balloon? If so, what size? So yeah, when you take the system out, you still have your wire across the valve into the left ventricle, and then you're advancing a sheath, usually just a 14 French sheath or 16, depending on what size valve platform you're using. And then you're typically using if you're using a true balloon, you're using a different size if you under-dilated the first time around. So, yeah. All right.
Yeah, exactly.
Hope that answered their questions. Yeah.
I think there may be one more slide if we're able to go next. Okay, so the 30-day results just show that this patient has single-digit gradients, so and no significant PBL. EF is preserved 68%. So the patient did quite well, and I think that the beauty of this intraannular valve is that if she were a person that for some reason 10+ years she were to need another valve, options are still open for her.
Perfect. So, and I noticed that all the gradients after these valves are single-digit, even there's a single-digit. I'm sorry. So most people say, well, it's intraannular versus supraannular, but in the way that these leaflets open is very different than for example, the Edwards valve, that they don't open completely. In this case, the leaflets open completely, and you always get single-digit and low gradients. So it doesn't really matter if it's intraannular or supraannular, at least in my mind and in our practice.
Yeah, I completely agree.
Okay. So we're going to go next. We're going to go next. So that's the second case we're going to present. So next slide. So this is a very peculiar patient. She's very educated, speaks several languages. She's a psychiatrist, 81-year-old with severe AS, class 3. Progressive shortness of breath, hypertension, hyperlipidemia, multiple comorbidities, including fibromyalgia, a fractured sternum, glaucoma, spinal stenosis, dysphagia. Her ejection fraction has been dropping. Her STS is in the intermediate to intermediate risk range. She had a cath where the right coronary artery that had a high-grade stenosis was stented without any complications whatsoever. The operator that did it did a great job. The radial access, the EKG shows right bundle branch block. As you can see, the renal function is preserved, and her pro-BNP is very elevated. So let's go to the next slide. So this is a case plan, and she qualifies for a 27th valve, and we chose this based on the features of the aorta, and that you will see in a second. The valve, as you can see, is very is significantly calcified, and the annular area measured 461 millimeters squared, so that was within a range for the 27 millimeter valve. Next. So the one thing, so here the sinuses of Valsalva in the left side, but then there's one thing that is pointed by the arrow, that there's an acute angle in the arch of the aorta that we felt could pose a potential problem. So let's see how things continue to go. Next slide, please. So that's again is a picture of that angulation, and you can see that when we advance the wire, you can see how steep that angle is. So we plan this case as a routine case, go with the inline sheath, pre-dilate. So let's move forward. So we got access as we always do. We pre-dilated. I think this was probably a 24 millimeter balloon. It's a true balloon, as you can see. The valve dilated and expanded well. We did not have any problems navigating over a Safari wire. In this case, Safari small curved wire. So far things are going well. Let's go to the next. Would you worry about anything else? If you saw that, bend. So the problem here is that we felt super confident, another routine case. Then we reached the top of the aorta, and then the system, as you can see, would just not make the bend. We just couldn't turn around. And then when we pulled back, what happened is that the coil in the Safari kind of unraveled and then locked with the shaft of the delivery system. So the wire and the system were locked, so we couldn't pull. And as you can see, we don't have enough. If we pull everything back, we don't have enough, probably enough purchase to keep the wire inside the body. So we would lose access. So very patiently, while sweating bullets at the same time, we were able to, with baby steps, like try to, and using sometimes the hemostat to try to advance the wire and pull and retract. So finally, we were able to do it. So now, we are having probably the most flexible valve in the market that is not making that turn. So what shall we do next? So next slide. So here are the options. Advance another Safari extra small and try again sheathless with Navitor. So Einstein had defined that trying to do the same thing again and expecting a different outcome is the same as madness. So probably not that. So insert the 20 French sheath and try again with the Navitor and a different wire, maybe like a Confida, or use a Vanderquist as a body wire that was mentioned before. Switch to a competitive valve. So what would you guys do?
That's a tough situation, and I'm sure, yeah, the sweating bullets is real. I would add, how about putting a Lunderquist in the LV? Do you ever do that anymore? I mean, we were doing that for all these 34 valves with the older self-expanding system. What do you? I try to avoid doing that if at all possible. But what about this case? What do you think?
I mean, it could have been a possible solution. What do you think, Amber? You're muted.
Yeah. So, just to backtrack, remind me, how were you able to take this out? Or
I was able to just very slowly push the wire in the system while retracting it. So finally, it kind of unlocked, right? It kind of unlocked. As soon as we got the valve out, we inserted the sheath. We passed the pigtail again into the ventricle. We pulled the Safari wire, and we noticed that the Safari wire had coils unraveled.
I think in that case, I would put a pigtail over the Safari.
Yeah, very patiently. Very patiently.
Yeah. Once you remove the Safari wire, I would be tempted to just put a stiffer wire. So my next step usually is go to a Lunderquist wire just for a little bit more support here.
Okay. So
not as a buddy wire, but as a primary.
Yeah.
Right. So we did not think, or we have radial access, not another femoral access to use the lander quiz. We'd have had to get the secondary access. So we didn't think about doing the lander quiz, although that's a very good strategy, as mentioned by Michael. And so what we did, we inserted the 20 French sheath because I dreaded the possibility of having this happen again and lose femoral access without having treated the patient. So for the 27 for the 27 millimeter valve, we needed to use a 20 French sheath. So we used probably one of the dry seal bore to do that. So, and we used a different wire. I think we used the Confida. So go to the next slide. The other possibilities were switch to carotid or subclavian access, or just stop the case and bring another day. So those were not very good. Alternatives. Although the carotid access we didn't think about because we were convinced, we were not intimidated by that bend that we saw in the aorta until we had to confront that during the case. Next slide, please. So this is the second attempt. I think that as you can see, very patiently, beat by beat, advancing the system. You can see that the valve in the left, just concentrate on the left panel. You can see that the valve, at some point, we get most of the capsule past, and then it kind of jumps forward. And obviously, we have good people holding onto the wire. And you can see, and then when that happened, we all took a deep breath, and we were able to cross the valve. Then the pigtail is interacting all over the place with the valve in that situation. So go to the next slide. So now it's time to deliver the valve. So we start to deploy the valve. The valve is being deployed. You can see we use the cusp overlap in the left-hand side. In the right-hand side, we usually go LAO and make sure that we are happy the way things are going. We're happy the way things are going. So next slide. In this case, we were happy with the depth of the valve. So we decided to just go ahead and release. And then one thing that this valve does, it stays in the same place. We have seen the other self-expanding valve that when you release, it usually does whatever it wants. Sometimes it jumps forward, sometimes it jumps a little bit upwards, and then if it goes almost to a zero level position, your possibilities of post-dilating that valve are almost non-existent, because the minute you expand that, the valve's going to pop out. But in this case, the valve usually stays in the same position when you release. Go forward.
I think that's a spot on assessment there. I find the same thing. Yeah, it doesn't cant nearly as much as the other self-expanding valves.
Yeah. So we were doing this case. Yeah. So we were doing this case with Jose Navia. He's the chief surgeon here in Cleveland Clinic, Florida. We gave ourselves a pat in the back, and then we just took a victory lap. There's no residual aortic insufficiency in this situation. The valve looks good. The gradients were the gradients were low, and unfortunately, she did have a vascular complication that required repair with so much manipulation going in with the sheath. This is a very frail patient. She's been exposed to steroid therapy, so her tissues were very, very, very friable. So then we can see that in the next picture. In the next picture, we'll see the hemodynamics. Okay, and here you can see that we corrected the aortic stenosis. And what I was telling you about the separation between the diastolic and the diastolic aortic pressure and the LVEDP here is good. The AI index, we used to calculate that in every case many years ago. We don't do it anymore, but we do look at that gap in between the LVEDP, and that's always, when you see that separation, that's always reassuring. So Echo, hemodynamics, and gradients, everything looked good, and we let our surgeon, our vascular surgeon, complete the case. The patient still comes, she brings me kosher wine every time she comes to a visit. So she's a delightful lady, and she's very happy, and she has a good quality of life. So this concludes my case. So we're gonna go to the question panel at this time, and so. So we have a couple, Nalima Katukuri, who is a friend, lives here in Florida. He's been very active, and we thank you for being so active in the chat. So these days we're using the dry seal when using the Navitor valves. That's that can be a good approach. I heard that from Amar Krishnaswamy in main campus in Cleveland Clinic, Maine, that they're using a sheath. I mean that's an alternative. If you wanna do that, we prefer to keep things minimal. I don't know how you guys do it, Michael. And
yeah, I'm interested to hear that actually, because I mean we do a fair amount of Navitor, and I usually don't use a sheath. I mean I'll use it if there's tortuosity, if there's calcification, certainly if we're worried about delivery. But we use pretty stiff wires, and so I've not found that to be an issue with getting the sheath in. I've actually found the opposite. I've found it's been very easy to use. I've liked the sheath upgrade that they've done with this valve. So we'll use dry seal, but not as default for this valve. I don't know, Amber.
And it's expensive. It's also expensive. Yeah. So you'll get administrators. The other thing is that this valve has a nice nose cone, and then there's hydrophilic coating. There's hydrophilic coating, so you don't feel like you have to really struggle to get it in when you exchange the initial sheet for the valvuloplasty.
Right. Yeah. If we have a stiff enough wire, I've just not found that to be too much of an issue. So.
Yeah, I in our institution, we're one of the highest kind of Navitor users in the country, and truthfully, I don't think we've ever used a dry seal. So I'm surprised to hear that people are doing that more routinely, especially with the low profile nature of this valve and the hydrophilic nature that's very flexible. I'm surprised to hear that a dry seal is needed. Makes it easy to post dilate and pre-dilate. So instead of a dry seal, what I would recommend then is actually to use a smaller French size sheath as your baseline sheet. So we use a 12 and a 14, depending on the size of the valve that we're placing. And we would just replace the sheath after removing the catheter delivery system to be able to pre and post. Because in my mind, there's no utility in exposing a patient to a vascular access complication by going up to a 20 French sheath for that purpose alone.
So I don't know how much the dry seal is, but I think it's significantly expensive compared to other sheets.
Yeah.
And then there's another question: why didn't I decide to use another access well? If I had, if I had the crystal ball, maybe I would have used. But I mean, did that bend look intimidating to you guys in the aorta?
Yeah.
Absolutely. Absolutely. I was sweating and I'm in the comfort of my home.
10 out of 10, 10 out of 10 there. I mean, good Lord. Yeah.
I think the other issue is, in some ways the tortuosity is bad on CT, but it's predictably bad. Coming from the carotid, usually you kind of go towards the inner curvature, but then with the other added tortuosity that you already had, it's a little less predictable, I think. Not to say it wouldn't have been a more direct and somewhat easier route, but switching mid-procedure is never ideal.
We have a question in the chat just real quick. Why does dilating a calcified valve or crossing through the aortic valve increase stroke rate? Well, anytime you're manipulating that calcification, and the more times you do that, the more likelihood that you're going to liberate some calcium debris. That's what causes stroke with TAVR. So that's why we would try to limit the number of pre or post dilatations we're doing and the number of times we're crossing these calcified aortic valves, because you're liberating calcium off of it, and that's what leads to stroke.
So I think that we are at top of the hour. I'm very, very pleased, very happy. I mean, amazing presentations by by Michael and Amber. I think we were able to carry excellent discussions. We brought some great points about the systems, about the rationale for using self-expanding, about the management of calcium, prevention of stroke, prevention of vascular complications. So I don't know if you guys have any additional words just to wrap it up.
No, this is great. A really good discussion, and thank you for the comments in the chat, and thank you for everybody for attending.
Okay, well, thank you so much. And then this is a wrap for this webinar. Hope to meet everybody in person at some point. And everyone, have a good night. And I hope that this was useful for your practice.
Wonderful. Thanks, everyone, for joining us.
All right.